to talk about a case of an unresponsive person brought to our emergency.
Okay.
On initial first 10-second assessment, patient were seen having tracheostomy tube and there were no central pulses palpable and the peripheries were cold and not responding to any commands. As we are not feeling any palpable pulse, we started with our BLS algorithm.
Okay.
First,
So we had a patient who was on tracheostomy,
yes.
wheeled into an ER, following unresponsive. What was the complaint that they said? They were having breathlessness.
Yes.
And on assessment, the patient was not responding. So when the patient was not responding, you went for your carotid pulse examination. At that time, you didn't feel a carotid pulse, and you went into the BLS
algorithm.
Okay.
As per the BLS algorithm, we check for the scene safety as
Okay. Verified. You have verified the scene safety. So
and
you have done that first. Okay.
yes, and then we check for the responsiveness
Which
of the
was not
patient,
there.
which was not there initially. And for the 10 seconds, we had to check for the carotid pulse.
Okay.
No palpable carotid pulse, and there was no chest raise.
Okay.
So as there is no breathing and no pulse left, we started with the CPR, initiation of the CPR.
Okay.
Chest compressions, as we are in the hospital setting, we had multiple workers present, so 30:2 we had started.
So the patient was unresponsive, there was no palpable pulse, so you went ahead with the BLS algorithm and you started with your CPR at a ratio of 30:2 and you checked pulse for 10 seconds. So what is the duration that you need to check for a pulse? Minimum duration that you need to check?
5 to 10 seconds.
5 seconds minimum, not more than 10 seconds. You don't want to waste time by checking for a pulse for a longer time. So 5 seconds minimum, maximum 10 seconds. So you have done that and there is no palpable pulse. So you called for help. So you had help already available. So you initiated the patient on CPR. Okay.
As the patient is having the tracheostomy tube, we directly we did some suction of the ET tube and we connected the ambu bag to the tracheostomy tube and gave the breaths.
So here my questions will be 3-4 questions that we need to answer because routine bag and mask is not going to help for this patient. So when you are going to keep a bag and mask above, it might help to some extent, but the patient is already having a tracheostomy. The tracheostomy tube or that pathway is blocked. That itself can cause hypoxia and the patient can have a cardiac arrest. So as you said that you have to check for the tracheostomy tube. You went with the checking for the tracheostomy tube. Whether it was patent initially,
it wasn't patent. There was a lot of secretions.
So a lot of secretions was there. So you cleared the secretion. Then you started giving your bag mask ventilation via the tracheostomy tube. So that is the reason might be. We don't know why the patient arrested. When we have to go back to the history, then only we will come to know. So right now what you have done, you have initiated CPR at a rate of 30:2 and you found out that the tracheostomy tube is blocked and you started suctioning. And what is the next thing that you will ask?
Next thing we ask is ask to connect the 12 lead ECG.
Not only ECG.
Sorry, defibrillator.
So the first step will be to start CPR. As soon as a device is available to analyze the rhythm, you need to connect to the analyzing the rhythm to a defibrillator or an AED. So in a hospital setting, you will get a defibrillator. So you connect to the defibrillator and see what is the rhythm. Whether it is a shockable rhythm or a non-shockable rhythm. Simultaneously, what you have to have, you have to give your team members a job and responsibility. So how many minimum people you require to run a code?
5 to 6.
5 to 6. So you can tell each one's responsibility. So you can, what is the role of the first person?
The role of the first person would be maintaining the airway.
So one to take care of the airway, bag mask ventilation. Second one
would be administrating first getting the IV lines and administering the drugs.
IV medications and the drugs. Okay.
And third one would be CPR.
Continuing the CPR. So what you can do, the person who is doing the compression and airway can interchange in between every 2 minutes or after every 5 cycles or whenever they feel exhausted. Ideally will be after 5 cycles of CPR or that is 2 minutes of CPR. So that will be the ideal thing. Then the next thing will be, next person will be, so one person to take care of the airway, one person to take care of the compression, third person is to administer IV access and drugs, fourth person would be documenting. Fourth person will be documenting. Fifth person will be the team leader, and sixth person will be the person who is administering the defibrillator. If needed to shock to deliver the shock, a person need to have an you should be keeping a person for defibrillation. So that is the ideal situation. So if you have 6 people, well and good. So if you don't have that, you need to share the responsibility. So depending upon the number of availability of resources, you need to decide how many people you can plan for a code. So here the most important thing, you have to give correct job responsibility, and you have to, one thing else you need to understand is that you need to make sure that they are competent enough also. So suppose you are telling a person who doesn't know how to operate a defibrillator, you should be giving them a responsibility, and that person also should clearly tell that he doesn't know how to do the defibrillator. So this part you should be very clear, and instructions should be very clear, and should be a closed loop communication. What do you mean by closed loop communication?
When you give the command, the other person should be replying the affirmative that I did that command.
Yeah, so it should be a closed loop communication that you need to maintain. So for this patient, what we have done, we have started CPR, and we have suctioned the airway, and simultaneously you have asked somebody to connect to the defibrillator. So what was the rhythm in the defibrillator?
The first was there was a sinus, there was a pulse, we could see the heart.
There was an organized rhythm. You can tell that way. Okay. Because organized rhythm was seen, but there is no palpable pulse. So we will name it as a pulseless electrical activity. So the patient had an organized rhythm, but the patient pulse was not palpable, so we can call it as a pulseless electrical activity. So this is the algorithm. We will come back to the algorithm again. So here is the pulseless electrical activity. So whenever you see a PEA or an asystole, what are the things that you need to do? See, PEA, it is very clear. You are seeing some rhythm in the ECG, but you are not able to get a palpable pulse. Continue CPR, give your first dose of epinephrine. So that is very clear. So suppose it is an asystole. What are the things that you need to do for asystole? You're seeing a straight line in the ECG. So what all things that you need before confirming that it is an asystole? What all things you need to do? Make sure that the lead is positioned on the correct place. Okay. And another thing is that you can increase the amplitude in the defibrillator and see whether we are missing a fine VF. So that is the most important thing. You need to make sure that the lead is correctly placed. Suppose, can you just share with? Suppose you are seeing a straight line like this. Yes, sir. So that means it is an asystole. See, now the new defibrillator, what they have done, no? The straight, if it is the leads is not in position, the straight line will look like this. It will not be a continuous line. It will be looking like this. Older defibrillator, even if the defibrillator is connected or not connected to the patient properly, it will be showing like a straight line like this only. So we are not very sure whether it is an asystole or whether the leads are not connected properly. But in the new defibrillator, when you carefully assess, you can see that it will be like this dotted lines. It will not be a continuous lines. So that is the difference that you can see. Okay. Then what can happen? No, suppose you can have fine VF like this. Okay. So this is a fine VF. Suppose you are magnifying this. Right. So you are increasing the amplitude. You will see something like this. So that is again a ventricular fibrillation. So the management changes. So it will go to this slip here. So then the treatment is not epinephrine, that is short. So whenever you see a straight line like this, two things that you need to keep in mind: whether leads are positioned correctly, lead position, and second one, fine VF, whether we are missing it. Fine VF. So what you have to do? Increase the amplitude and see. So these are the requirement that you need to look into. Okay. So here you are confirmed that it was a PEA. Yeah. Then you started him on what?
First we got the IV line access.
IV access.
Yes. And continuing the CPR itself without stopping the CPR anything as of now. Okay. Getting the IV access, and then after the 2 cycles, 2 minutes or the 5 cycles.
So you started with
epinephrine.
Epinephrine. First dose of epinephrine. What is the dose of epinephrine? 1 mg.
For every 3 to 5 minutes we need to give. But 1 ampule contains 1 mg. That one.
You gave it every 3 to 5 minutes. So that is the first drug that you need to administer whenever you are having a patient with asystole or a PEA. Then what else? You have to continue the CPR, and after 2 minutes, what all things they can interchange between the rescuers. And the other thing, what you need to do, you need to continue doing CPR, and every 3 to 5 minutes you need to repeat. Then you can continue.
So after the first cycle of the CPR and next when we had checked the pattern in the defibrillator, we had seen that there are broad QRS like VT pattern.
So what you have done, the patient had a PEA and you started him on CPR. You gave him first dose of epinephrine, and after the next assessment, at the time of next assessment, you found out that the ECG was showing a wide QRS rhythm. Is that correct?
Yes.
So wide QRS rhythm, what are the possibilities of a wide QRS rhythm? Whether it was a regular or an irregular rhythm?
It was a regular.
It was a regular. So can you draw how was the rhythm? It monomorphic or polymorphic? You can use the other side. It is blacks. Okay. So what is this?
White.
So rather than this, it would have been something like this, no?
Yes. Okay.
Something like this.
Yes, sir.
It's a white QRS
Yes,
rhythm, what you are able to see. So white QRS rhythm, all are looking same morphology. So what we can do, white QRS, white QRS, monomorphic, white QRS rhythm, monomorphic, possibly what we are dealing is a ventricular tachycardia. So ventricular tachycardia, what is the treatment? Whenever you see a shockable rhythm, what is the first treatment? You need to administer shock. So
as ours is a biphasic shockable rhythm, we started first with the 200 joules of.
Okay, so you started with the 200 joules of shock. So what happened? You have just first it was a PEA, yes, right? Then epinephrine was given, epi was given, and one cycle of CPR was continued. Later on, at the time of second assessment, it was showing a ventricular tachycardia. So you delivered shock with a biphasic defibrillator. What we are having, it is 200 joules. You have given a biphasic defibrillator, VT, and shock was delivered. And soon after, what we have to see, we have to continue CPR, resume CPR. During giving the shock, initially it has to be charged. So during the charging time also the CPR should be continued. So CPR needed to be continued and resume. And soon after delivering the shock, you have to resume the CPR also. Okay. So the CPR was resumed for him. Then what happened? And the second dose of epinephrine every 3 to 5 minutes was given. And now what has happened? The patient had an PEA. Every 3 to 5 minutes you are continuing. See the problem. This is an algorithm here. So what has happened from here? We have jumped to this place, right? Yes. So from it is now a shockable rhythm. So when it is initially it is a shockable rhythm, epinephrine we will give only after the second shock. Okay. You can see that in the algorithm. Yes, first it is shock, then second also it is shock. Only we will give epinephrine. So what happened here? Initially it is started with a PA, so we gave epinephrine already. Then later on it became a shockable rhythm. So when we have delivered the first shock, second shock, then every 3 to 5 minutes we are continuing your epinephrine. Okay. Then again after the 5 cycles or the 2 minutes we again assessed the rhythm. Okay. Again the rhythm was the same monomorphic wide QRS complex. Monomorphic VT. Again you have monomorphic VT. So what we have done? We repeated the shock of 200 joules. 200 joules you have repeated. 200 joules you have repeated. And what else you need to do at this juncture now? You have given 200 joules of, you have given the second shock. So here, second shock of, second shock was given. What do you need to do at this point of time? At this point of time, an epinephrine or the capnography, as we have already have a. Okay, capnography can be done. So capnography will come to later. Okay. We will discuss regarding capnography later. See what you will say after the second shock. You deliver the second shock. Yes, so what are things you need to consider? You need to tell your medication person to prepare and keep ready what? Amiodarone. Prepare amiodarone. Don't give amiodarone. You can ask them to prepare amiodarone. Yes, so amiodarone, how much is the dose of amiodarone that you need? Initial administering dose would be 300 mg. So 300 mg for an adult patient. Yes. So you ask them to prepare amiodarone and keep ready. Continue CPR and reassess the patient after 2 minutes. Then you see whether it is still a shockable rhythm. So what happened to this patient? Again, it was still a shockable rhythm. So again, it was a shockable rhythm. So you administer the shock, and after that you administer 300 mg of amiodarone. So this is the time when amiodarone comes in place. If you don't have amio, what else you can give? You can also have an option of giving lidocaine. So lidocaine, again the dose is 1 to 1.5 milligram per kg. So what happened to this patient? In a nutshell, we'll just see. 1 second. We have put that chart. This no? Okay. No, it's not there. Okay, that's fine. So we can just write it down. Okay, we can just write it down whatever has happened. So first, patient was brought to PEA. Then he went into VT. Shock was given. So shock was given. Then again he was in VT. Here so also again shock was given. So initially we gave 200 joules of shock. 200 joules we have given. Here
Here also 200.
200. If the defibrillator have increased facility,
next we gone to 270.
270. So then we are gone to, again it was VT. So what we are given? It is 270 because our defibrillator 270 is present. You can give that also. It is again a biphasic defibrillator and shock was given. So third shock with amiodarone. Amiodarone was given. So this is what has happened to this patient. Of 300 mg. 300 mg of amiodarone was given. Okay.
And after this again the CPR was continued.
Okay, so CPR was continued. CPR continued.
After which again we had checked the rhythm, again it is still in VT.
Oh, again the patient is in VT. So what we can call right now, we can call it as a refractory VT. So refractory VT. So refractory VT. Now what we have to look is for, we are looking for any other reversible causes. So
during this entire course we had run for our labs of electrolytes.
Okay. And you have asked for an ABG.
ABG.
Okay. So we'll just see what was the ABG value. Okay. You asked for your ABG. So ABG, can you just tell me the
in this ABG finding, we found that the saturation was only 38% and the PO2 was only 28. On arrival, we had immediately done. This is on arrival time of the ABG.
So on arrival, there is hypoxia. There is hypoxia. The ABG. Hypoxia. Then potassium looks okay. 4.5. There is no hyperkalemia. There is no major acidosis. Also no. So primarily lactate was on the higher side. Lactate was on higher side, 7.8. So
cold peripheries was also
increased lactate. That is the only thing that you got. So what could be the reason for cardiac arrest here? Might be due to the tracheostomy 2 block. We are not very sure. It can be due to tracheostomy 2 block. So what you have to look in for, you have to understand is you have to look for the reversible causes of cardiac arrest, which you have already done. So now this patient had refractory VT. So refractory ventricular tachycardia. So refractory VT. So we have given 4 shocks, right? 4 shocks and 300 mg of amiodarone, and also plus 150 of additional. So 150 mg of additional amio was given. Okay, so refractory VT, 4 shock has been delivered, 300 plus 150 mg of amiodarone was given. You look for any reversible causes, only you found out is what is hypoxia. So anyway, you are doing bag mask ventilation, that would be sufficient for doing for this. Then
so then the patient had again got a irregular waveform, but still pulseless.
It was like this, or it was like this?
It was like this. So there was some, even the waves were irregular, not on a regular
beat. So it was more in favor of an ventricular fibrillation, something like this. Something like this, what you got. So it is more in favor of a VF. Again, the treatment is the same. CPR plus shock plus whatever your drugs. Already you have given all those drugs. So again, it is the same thing. But what all things that you have done, possibly you have done for this patient, is continuing the CPR that you are already doing, and already you are administered amiodarone. Suppose you are seeing a rhythm. Yes. So what is this rhythm? It is otherwise called as polymorphic ventricular tachycardia, or we can call it as torsade. So suppose you are seeing a torsade, what is the treatment that you need to give? Magnesium sulfate. So the treatment is magnesium sulfate. Magnesium sulfate, 2 to 3 grams you can give as an IV stat. So if you are seeing a torsade, you could have given this. If you are not seeing a torsade, we just need to continue you are giving whatever drugs we have given. Okay. So
after this multiple events of CPR and the shocks, the patient had developed asystoles.
Okay. So the patient, you can just go back to the previous. Yeah. So the patient was not recovering, so he went into asystole. So you tried CPR and she was not recovering. So how long you have continued your CPR?
Till now, like 7 cycles have over.
Not 7 cycles. See, one cycle is 30:2. So one cycle is 30:2. So 5 cycle
2 minutes.
2 minutes.
So that's 2 minutes into 7.
So 35 cycles. So most likely you have completed like some more around 20 minutes of CPR. So you have completed 20 minutes of CPR. and it was showing asystole. Asystole. Now at this juncture, what you can look in for is what? We need to use our capnography here. So how does the capnography help at this point of time? So capnography role of ETCO2 in cardiac arrest. Can you tell me one?
It will be telling about the CPR quality.
Quality of CPR, most important. Quality of CPR. Quality of CPR. So what does it mean? If it is less than 10, we need to improve the quality of CPR. So suppose they are not doing here feedback device. You should have feedback device. Suppose it is less than 10, you should to tell your team members to improve the quality of CPR. 2. Confirm the ET position. Here it is already endotracheal tube. So confirm the position of endotracheal tube after you securing the airway. 3. What does it? How does it help? If you are continuing CPR for more than 20 minutes, okay, and ETCO2 remains less than 10, even after improving the quality of CPR, then chance of recovery is less. So you can consider stopping your CPR. If ETCO2 is persistently low after 20 minutes of CPR, you can think of stopping your resuscitation. So that is how it will help. ETCO2, one thing, to improve the quality of CPR and confirm the ET2 position. And third is, if it is persistently low, it will also help us to whether we can stop the CPR. And also there is one more help. If there is a sudden increase in ETCO2, ETCO2 has suddenly increased while doing your CPR. So what does it mean? You have achieving return of spontaneous circulation. So these are the 4 things that you can remember the role of ETCO2 in case of a cardiac arrest. So one, in case of confirming your 2 position, that you can do in any patient, not in cardiac arrest alone. Any patient. Second will be to understand the quality of CPR. 3, to terminate the CPR and whether we are achieving the return of spontaneous circulation. Unlikely this patient didn't survive. So asystole was persisted and she was declared dead, right? So in spite of her repeated resuscitation effort for more than 30 minutes, there was no improvement in her. So suppose this patient improves. Okay. Suppose this patient improves, what are things that you need to do?
Suppose this patient improves, then we need to go to the next algorithm.
Otherwise, what we can tell, we can achieve return of spontaneous circulation. So suppose he has achieved ROS, you can explain each one of these things.
After achieving ROS, usually we need to place an advanced airway.
If not placed in the other assessment, if it is placed already, no need to have an advanced airway.
Then we already, in this case, we already have an advanced airway.
Okay.
So we can use the help of the ETCO2 to monitor his achievement of the ROSC.
Okay.
After achieving the ROSC, first thing we need to titrate is the respiratory parameters of FiO2.
Okay. So what targets, you can just write it down because it will be little bit bold. You can use the other side.
We check for the SpO2
target of
92
to 98%. So 90, that is our target. Yes, we don't want 100%. We don't want very low also. 92 to 98. Then
PCO2 of 35 to 45.
Normal PCO2. That is what we are targeting. 45 mmHg. It is not percentage mmHg. Okay, fine. Then respiratory rate of approximately 10 to 12 breaths per minute. You can target at 10 breaths per minute. So that is the requirement. Then blood pressure.
Systolic blood pressure of greater than 90. Mean arterial pressure of above 65 is the target.
So suppose you have achieved a return of spontaneous circulation and you have already secured a definitive airway. These are the targets that you need to maintain. Then what else is the next step?
Then we take a 12 lead ECG.
And depending upon the ECG, because what we have to see that primarily there can be an acute coronary syndrome that has caused the cardiac arrest. So you have to see whether it is an ACS. Yes. You take an ECG and see for any acute STD changes or a new onset LVV or anything. Then if that is the situation, that patient should be shifted to immediately to a cath lab. Then next thing
is we check whether is his response to commands and the GCS per se. If it is comatose or non-comatose. If it's a comatose patient, even we need to monitor his temperature and other parameters.
We need to go for the something called as the
targeted temperature management.
TTM. So targeted temperature management. So what is the targeted temperature management?
32 to 36 degree for 24
hours. 32 to 36 degree for 22 hours. So 32 to 36 degree Celsius for the 24 hours. hours. So that is the target for that we need to achieve for, and if needed, CT brain, EEG, everything can be taken depending upon the patient's hemodynamic stability.
Even the EEG to remove the non-convulsive
status we can ask him for. Then always remember the
5H and
5Ts. So these are the 5H and 5Ts are the reversible causes of the cardiac arrest. So H is for your hypovolemia,
hypoxia, hypo and hyperkalemia, and hypothermia,
hydrogen
acidosis. And T's are the thrombus of the cardiac cause or the pulmonary cause, and tamponade, tension pneumothorax, and the toxins.
Okay.
In our case, it most probably would have been in hypoxia.
Hypoxia related, that is what ABG was. Okay. So we'll just go back to the algorithm here again. So we'll just start with the BLS algorithm again. So suppose you have a patient who is unresponsive coming to your scene. The first thing, check for responsiveness, shout for help, and activate the emergency response. And depending upon that patient, you can have three types of patient. You can have normal breathing and pulse is felt. Normal breathing and pulse is felt. No normal breathing and pulse is felt, and no breathing, only gasping or no pulse is felt. So one is breathing is there, but pulse is absent. Present also. This one, pulse is present is also. So what you have to do till the emergency help arrives, you can keep the patient on a recovery position, or you need to look for the other causes why he is not responding. Maybe a hypoglycemia, hypotension, all those things you need to do. So that is the patient number one. Second group is that you have a pulse, but he is not breathing well. So just continue him with a bag mask ventilation for one breath every 6 seconds. So that is the BLS algorithm that we need to remember. Suppose there is no breathing or only gasping or no pulse is felt, start CPR immediately at a ratio of 30:2 and make sure that you are giving something called as an high quality CPR. High quality CPR. So what are the components of a high quality CPR?
There are a few characteristics with criteria. One first would be 5 to 6 centimeter.
100 to 120 compression in a minute. Then, as you said, 5 to 6 centimeter depth.
And it should allow it to recoil.
Complete recoil should be permitted. Then what is the other? Minimize interruptions. Minimize interruptions. Interruption should be there. If it is not, it should not be more than 30 seconds. So minimize interruptions. Then one more is there. There are 5 qualities. 100 to 120, 5 centimeter depth, recoil, minimize interruptions, and one more.
Yes, sir.
Huh? This here. Avoid excessive ventilation. So you have to avoid excessive ventilation. So each breath should be delivered over a period of 1 second and should be not giving an excess, just to have a chest rise. So avoid excessive ventilation, allow adequate chest recoil, give a compression of 100 to 120 compressions in a minute. Then we have to do 5 centimeter depth, that is what you need to look in for, and minimize interruption. So these are the 5 qualities of CPR. So you started the CPR, then whenever a monitor is available, you have to see whether it is a shockable or a non-shockable rhythm. Depending upon that, a shockable or a knock-on shock rhythm, we have got 2 limbs. Which is a shockable rhythm, straight away you can deliver the shock. So don't pause the CPR. By the time you prepare your defibrillator, then you charge everything, then you deliver the shock. And after 2 shocks, you can give epinephrine. And you prepare amiodarone, and after 3rd shock, you give amiodarone or lidocaine and look for the reversible causes. Whenever possible, look for the reversible causes. Assisted over PA, it's very easy. You have to give adrenaline or epinephrine every 3 to 5 minutes repeatedly, and you look for the reversible cause of cardiac arrest. So it is pretty simple. Once you achieve the return of spontaneous respiration, you go into a post cardiac arrest algorithm, which targets we have already mentioned. So this is what you need to remember regarding the ACLS algorithm. Anything else that you need to add on? Nothing else. Okay. Thank you.